This conference will now be recorded.
Okay. So, Rasha?
Yes, doctor.
Rasha, can you hear me?
Yes, I can hear it.
Can you answer this question? Can you read it loud and answer it?
Which muscle pair receives innervation from C5?
Pronator teres. Pronator teres, it's in the forearm. So it's not
the deltoid
proximal.
and maybe the deltoid and coracobrachialis.
That's correct. I mean, coracobrachialis and deltoid, these are proximal muscle. These are C5, C6. So, okay. Abu Naib?
Yeah, deltoid innervated by 5 and 6.
Deltoid 5 and 6. And which nerve?
Deltoid, a different nerve, one auxiliary and one
auxiliary. That's a, yeah, auxiliary. Yeah, thank you. Okay, and whom do we have here? Can median. So abductor pollicis brevis is median nerve, and the nerve root, it's in the hand, intrinsic hand muscle. C8. Okay, so if from the location of the muscle you can guess which nerve root is doing this. This is very difficult question. This is difficult. This is for Mus'ab. Now I want the best answer. There is two right answer, but what's the best answer? Okay, good. Correct. Okay. So Mus'ab is saying deltoid is not, because deltoid C5, 6 and intrinsic hand. I'll go for C, but the main issue is, triceps, extensor digitorum, and supinator. These are radial nerve innervated. So when you say C7, you want a muscle that's not radial. If all of the muscles I put here are radial, they are C7. They have C7 innervation, but they all are radial. So, when you make the diagnosis of C7, you want a non-radial muscle. So the flexor carpi radialis, even the name is a flexor carpi radialis, but we know all the flexor are not radialis, or the extensor are radialis. So this is innervated by the median nerve. So this is median nerve and C7. Okay, so this is kind of like the best answer. So sometimes, you have to pick the best answer out of them. For the sake of time, I'm not gonna go in details, but Dr. Fateh did a great job when he discussed the brachial plexus. But for our internal medicine people, I mean, roots and then trunk. It's like the tree root, and then you have the trunk. C5 and 6 will make the upper trunk. So anything that has C5 or 6 innervation, part of the plexus, gonna come from C5, C6. So, deltoid fibers gonna run from that because they are C5, C6. Biceps muscle gonna come from the upper trunk. Okay, and then it's gonna have anterior and posterior. The anterior will continue in the lateral cord, and the posterior will join, the middle trunk to form the posterior cord, and then C8, T1 will give you the lower trunk, which will continue as gonna give a small branch, posterior branch to the posterior cord, to make the posterior cord, and then continue as the bad things that doesn't show on the screen here. But you cannot see in the mouse. I'm moving it. Then it's gonna make the ulnar and the median nerve. Just in a brief. It's very important to remember that the long thoracic nerve come proximal to the plexus, so it will help you sometimes differentiate between radiculopathy or plexopathy. They love to ask this question in the board exam and in the right exam. So if you want to differentiate, you pick the long thoracic nerve. Also, the dorsal scapula also can be helpful in differentiating radiculopathy versus plexopathy, because they originate prior to that. This is not always true. If it's a stretching injury, yes, probably it's a true. But if you have inflammatory process, sometimes it's not true. It's sometimes important to know which nerve root innervate which muscle and what's the function of the muscle. One of the right exam questions was, Ali is not with us. Is Ali? Ali, are you there? You are not. Rasha, I'll go back to you. Are you there?
Yes, I am here.
Latissimus dorsi. What nerve
Yes.
and what root? And if you
Latissimus
tell me the function,
dorsi,
yeah, go ahead.
the thoracodorsal nerve.
Thoracodorsal. That's great. And it comes from?
It's from
Thoracodorsal
the
comes
posterior
from
cord.
posterior cord. So what's the latissimus dorsi does as a function? This is a difficult question.
Internal.
It does two functions. It's adduct and internal rotation. So teres major and latissimus dorsi does the same thing. Okay. So of course the strongest adductor of the arm is the pectoralis muscle. Then come latissimus dorsi and teres major. Yeah, correct. Now the opposite, which muscle do the external rotation? If you want to remember it, it's SIT, it's supraspinatus, very weak, infraspinatus, and teres minor. Okay, these sometimes important when you want to do the examine the patient function. Okay, so let's move to more questions later on. The suprascapular, we mentioned it, supraspinatus and infraspinatus muscle. Now, Abu Nayib, can you pick for A? A, which item fits for A? A abducts the shoulder through the first 15 degrees.
Deltoid.
No. The supraspinatus muscle does the first 15 degree. Okay.
Yeah, then
so
deltoid,
deltoid 15 to 90, and serratus anterior and trapezius will do above the shoulder. Great. Okay. We'll try to move a little bit faster. Very important to remember that the medial lower trunk, medial cord, will have the innervation of the medial aspect of the arm and forearm. That's sometimes very helpful in localization. Okay, we discussed these. So, Rasha?
Yes. Which of the following combination of deep tendon reflex abnormalities is seen in an upper trunk brachial plexopathy? Upper trunk.
So upper trunk is made of what?
C5, C6.
C5, C6. So which reflexes goes through C5 and 6? Which muscle? Biceps?
Yes, and the deltoid as well.
So biceps and brachioradialis, correct?
Okay.
Biceps C5 and 6 and brachioradialis C5 and 6. So we'll lose these reflexes. Now, yeah. And now which one will be preserved? The triceps. So if we change the question is, which of the following combination of deep tendon reflexes abnormality is seen in lower trunk, Abu Nayib? So which reflex you will lose with lower trunk?
The trunk, the triceps, and the finger reflex.
The lower trunk is made of what?
Lower trunk is 8 and T1.
T1. Okay. So the triceps
Yeah.
is 7 mainly. So it's not.
No, triceps. The flexor, the finger reflexes.
Finger flexor, yes. It's not one of the major ones, but yes, correct. And if you have middle trunk, you will lose C7 only.
The trunk, triceps, yeah. Triceps.
Yeah. Okay. So I mean, this is kind of like a material for 3 questions. I mean, you guys know this. So anybody here from the audience, Musab? Can you hear Musab when he read the question, or
Very low voice.
he will come closer?
Very low voice.
45-year-old man is referred to the electrodiagnostic laboratory for evaluation of brachial plexopathy. On examination, he is noted to have severe atrophy in the face dorsal interosseous muscle. Slightly localized to which part of the brachial plexus? Lateral cord, posterior cord, upper trunk, and or lower trunk. Face dorsal interosseous muscle are innervated by ulnar nerve, and ulnar nerve is part of the medial cord and lower trunk.
Correct.
So the answer will be lower trunk.
Lower trunk. Even if you don't know, it's intrinsic hand muscle or the intrinsic hand muscle are C8, T1. So we're talking our lower trunk. If lower trunk is not an option, medial cord. Okay. So I mean,
median nerve is not supplied by intrinsic muscle, the median nerve.
Yeah. The median nerve, 2 part. C6 and 7 come from the lateral cord, and C8, T1 comes from the lower trunk. So the medial comes from the lateral and the medial cord. Okay. So okay, Rasha.
Yes, 25-year-old woman presents with chronic left shoulder pain and sensory symptoms in her left hand. On examination, she has atrophy of thenar and hypothenar muscle groups in the hand. Examination showed decreased sensation over 4th, 5th fingers, medial aspect of the arm. Based on these findings, which of the following conditions is likely?
From the case, can you walk us around? So I mean, she has atrophy of the thenar. So thenar muscle mostly.
The thenar median.
Thenar median, except one muscle. So what are the thenar muscle?
Thenar muscle. I don't remember them. Flexor digitorum. I don't remember.
Brevis. Flexor digitorum. No. So I'll go. So epiductor pollicis brevis. Okay, that's a median. A flexor pollicis brevis. Okay, and opponens pollicis. These are median. The ulnar one is adductor pollicis. Okay, so these are the thenar muscle. So these are C8, T1. Okay, and then the hypothenar muscles innervated by ulnar. These are ulnar innervated, and these are C8, T1. So C8, T1, we have C8, T1 roots. We have lower trunk. Then they're gonna go through the medial cord. Correct? Now you have decreased sensation over the 4th and 5th finger. This is
the medial cutaneous nerve of the forearm.
Okay, the medial aspect of the arm. We'll go with that. So now where do you localize your lesion, Rasha?
A?
Is ulnar neuropathy will give you numbness in the medial aspect of the arm?
No.
No, because it should stop by the rest. Okay.
So only medial cord.
Medial cord plexopathy. Okay, that's correct. So from look. Martin Gruber is an anomaly. It's an anomaly. It shouldn't give you that with carpal tunnel. So from the localization, this is C8T1, medial cord or lower trunk. But we have medial cord here as an option. I mean, this is how it goes. Whom I didn't mention the name of. Tahira, can you do this?
She has atrophy of the thenar and hypothenar muscle groups in the hand. Nerve conduction studies were performed. They showed decreased medial and ulnar motor amplitude. Ulnar sensory response was absent, whereas medial sensory response was normal. Based on this finding, which of the following condition is likely?
So it's the same case, but there's some changes. So we said that she has thenar and hypothenar atrophy, but we did a nerve conduction study here. Instead of mentioning the sensory, so she has decreased median and ulnar motor. We expect that because of the atrophy, and ulnar sensory response was absent, whereas median sensory response was normal.
Neurogenic thoracic outlet syndrome.
That's correct. It's a neurogenic syndrome outlet. Can this be C8T1 radiculopathy? Usually, if it's radiculopathy, you should not lose the sensory nerve action potential, and you lost it there. Okay, because C8T1 innervate most of the hand muscles, so you can still see the atrophy. So that the abnormality in the nerve conduction study is ruling out C8T1. So you are left with neurogenic or medial cord. Okay. So neurogenic.
And usually in the female in the lower trunk, yeah, doctor. You said that last time, yes?
In the female, it's lower trunk.
Usually.
What's usually in the female? The neurogenic thoracic outlet.
Yeah,
usually
yeah,
Yes, it's lower trunk, because if you see the picture, usually you have a fibrous band between the rudimentary rib and the first rib. So it will be usually in the lower trunk. In the past, they used to diagnose this a lot, but they were overcalling it. Okay. Usually, it has preference to T1, and we think that epiductor, we think the thenar has more T1 than the hypothenar. But when you go, which one has more T1 and which one has C8, each author will differ. So I don't want to confuse you. But usually, the typical feature of thoracic outlet, you will have numbness in the ulnar distribution, and you have atrophy in the thenar. That's the most typical feature. If you see that, because it doesn't make sense when you have somebody has thenar atrophy and numbness over the hypothenar area or over the fingers. Okay, who's in the? I don't see who are in. Who's in the with us? But I didn't ask him to read. Okay, this is for Musab. This question.
Medial EMG. Which of the following muscle can differentiate a medial cord brachial plexopathy from lower trunk brachial plexopathy? First dorsal interosseous, abductor pollicis brevis, extensor digital, indicis proprius, flexor carpi ulnaris.
ده فعلا لازم يكون مصعب.
No, the previous case, all of them, they could have lower trunk or medial cord. So
from this graph, extensor indicis proprius.
Okay, yeah. So because this is C8 and it's radial, but it goes through the posterior branch. Okay, so if you want to differentiate, you have to examine this muscle or stick a needle in that muscle, because it's mainly C8. Finger extensor C7, C8, but this is mainly C8. Okay, we go back to Russia.
Yes, okay. A patient is referred to neuromuscular clinic for evaluation of brachial plexopathy. On examination, he was noted to have weakness in the deltoid and triceps. However, the pronator teres muscle and bicep brachii were strong. Presuming that pathology is in the brachial plexus, these findings are best localizable to which of the following structures? Medial, lateral, or posterior cord, C5 or C6 roots.
Okay. The pronator, let's go with something easy. The biceps comes from which nerve innervate the biceps?
The biceps.
Musculocutaneous. Musculocutaneous comes from the lateral cord. So the lateral cord is fine. Okay. And also the pronator teres comes from the middle cord, you know, and lateral because it's C6, C7, correct? Let's say you don't know that, that's fine. Now the deltoid and the triceps, let's say the triceps, we know it's C7, so C7 will come from the middle cord, then posterior cord, and C7 is affected. So it's
medial cord.
So see the dot is the affected muscle. So the triceps, if you see, mainly C7, I put C7, come, you see the, let's see my arrow, see C7, that's the middle trunk and posterior cord. So this is affected, correct?
Okay. Yes.
Is it clear?
Not. Can you repeat, please?
Posterior cord. Okay, we'll go back. So the affected muscle are the deltoid and the triceps, correct?
Yes.
Let's go with the deltoid. Deltoid is what? It's C5 and C6. So C5 and C6 will go through the upper trunk, and then from the upper trunk, they will go to the posterior cord. So the lesion either in the if I tell you the deltoid is affected, that means the lesion is in the upper trunk or posterior cord. But we have something that goes through the upper trunk, which is the biceps, and it's not affected. So the biceps, so it's fine, the lateral cord, because it goes through the lateral cord. It's not only that, you know, the pronator teres also, it's C6 and C7, but goes through the lateral cord also. So the problem is not in the lateral cord. The medial cord is none of the muscles that we mentioned goes through the medial cord. So nothing in the medial cord. So we are left with the posterior cord.
Yes.
Is that more clear now?
Yes, clear.
Okay. So we have Rasha and Abu Naib. Who else in the net? Can you guys see? There is more than 2 people on the net. Oh, Tahira was on the net. Okay. Okay. So the one who know the answer can shout it out. Patient presented with weakness of the right shoulder abduction and numbness of the skin overlying the lateral deltoid. Otherwise unremarkable exam. The most likely etiology is. So the strongest shoulder abductor is? Deltoid. Correct. Deltoid. Okay, so it's the axillary, because the axillary does innervate a small patch over the deltoid skin. So this is the axillary nerve. Okay. In a patient with shoulder girdle weakness, so all the proximal shoulder muscle are weak. Needle EMG abnormality in which of the following muscle localizes the lesion to the cervical roots? I mentioned that in the beginning. So, you know, which will make it serratus anterior. Okay. How can you pick serratus anterior abnormality?
Winging of the scapula.
Okay. So the scapula, if you look at, I mean, the serratus is connected between the dorsum of the scapula and the middle anterior part of the ribs. So it will stabilize the scapula to the posterior wall. If it's weak, then the medial aspect will wing. Okay. And usually it will pull the trapezius and the serratus anterior will pull them more anteriorly. So when they are weak, the rhomboid will pull them back. So actually it will be closer to the midline and winging, okay?
Okay.
So a 45-year-old woman had axillary neuropathy after a trauma. Okay, needle exam of which of the following muscle is going to reveal denervation? We just mentioned axillary innervate the anterior
Deltoid.
minor. Anterior minor, correct. Okay, so this is just a picture of the axillary. Now yes, correct, and that's the skin in the lateral aspect. Okay, the following nerves has both motor and cutaneous sensory function. You know, we have motor nerve, we have sensory nerve, and we have mixed nerve. So all of these are mixed nerve except suprascapular. Okay, we know that. Remember, I mean, even we're not discussing the lower extremity, but the obturator has a small innervation in the medial upper thigh. Okay. A 35-year-old man presents with right arm weakness. On examination, he has weakness of the right elbow flexion. So elbow flexors. Okay. Keep in your mind what's the elbow flexor? Can be biceps, brachioradialis, and brachialis, okay? But other muscle group are strong. He also has sensory loss over the lateral forearm. Which of the following is the most likely cause of his clinical musculocutaneous? And the strongest muscle of these is the biceps. The biceps is a flexor. It does another function, supination, okay? So even if the patient has a radial injury and we have some supination, so we'll still have some supination from the biceps. Remember, if you do this, it's actually supinated. If you do it in pronation, this is the brachioradialis. This is the biceps, okay? Great. We have a smart fox, and this is the here. Now, of course, again, not everybody will agree. Coracobrachialis, usually the musculocutaneous is mainly C5-6, and coracobrachialis, I think, is mainly C5-6. So
why is not the lateral cord, Dr. Hattou?
Why it's not lateral cord? Because it's only limited to the flexion.
Biceps?
Mainly limited to the biceps. It's not. There is no other muscle group because I mean you.
Median. No median muscle.
There is no
median
pronator
nerve.
teres weakness, for example. So it's just very limited. Okay, Mus'ab.
Distinguishing between an ulnar nerve lesion at the elbow and one at the wrist. Sensation over the fifth finger. Sensation in the distribution of the lateral antebrachial cutaneous nerve. Sensation in the distribution of medial antebrachial cutaneous nerve. Sensation in the distribution of the dorsal ulnar cutaneous sensory nerve. B and C are wrong for sure. Yeah. Sensation, it will be D. Yeah, sensation in the distribution of the dorsal ulnar cutaneous nerve. This is branch coming before the Guyon canal.
Great. Okay. So that will help you differentiate between a proximal versus a distal. And this is from Professor Mus'ab presentation. Okay. So it's the same thing. A nerve entrapment at the Guyon's canal leads to abnormality in which of the following nerve muscle pairs in electrodiagnostic testing? Is it the median? Is it the radial?
B, ulnar nerve.
Okay.
B.
So Abu Naib, why not D?
D is the proximal lesion usually.
Yeah, flexor carpi ulnaris proximal. This is the first innervation from the ulnar at the elbow. Correct. Okay, well, you guys know this. You know that. Let's do a couple of few questions here. Rasha?
25-year-old woman noticed numbness in her left hand after she started wearing a new tight-fitting bracelet. On examination, she has sensory loss of her dorsum of her left hand. There was no clear weakness on examination, and deep tendon reflexes were normal. Nerve conduction study was requested. Apart from routine testing, which nerves should be tested to localize her neuropathy?
So she has only numbness, and numbness is in the dorsum of the left hand. And I'll make it more easier, dorsum of the first 3 fingers. So which nerve does that?
The radial nerve.
The radial nerve. So, I mean, where can you compress the radial nerve without having any motor symptoms? And see, she was wearing a tight-fitting bracelet. And also sometimes in the past, you know, when they cuff somebody, police cuff somebody, if it was very tight, it was causing compression to that nerve. Okay. So which nerve you wanna? I mean, you mentioned it's radial, so radial motor or sensory you wanna study?
Sensory.
Okay. Why you wanna it says bilateral. Why not one side? Because you wanna compare between
Maybe
the right and the
normal.
left. Yeah. Okay.
Okay.
Which of the following muscles usually gets innervation from the musculocutaneous nerve and the radial nerve? Brachialis. Okay. So usually it's musculocutaneous, but in 70 to 80% it get innervation from the radial nerve. Okay. Now, which of the following test aids in differentiating posterior cord plexopathy from radial neuropathy?
Elbow extension. Elbow extension.
Shoulder abduction, because that comes from the axillary. Okay. Okay. And Abu Nayeb?
Patient present with wrist drop, mild weakness of supination and elbow flexion, and sensory loss of the dorsum of the hand. Elbow extension is strong. Radial neuropathy is suspected. Where is the lesion most likely to be located? Just above elbow.
What did you say? It's above the elbow, but where above?
Spiral groove.
A spiral groove. But remember, I mean, he has mild weakness of the supination because the biceps is still intact. Okay. Okay.
Yes.
So let's see. This is for Musab.
Invasion.
Yeah, yes, it's Saturday night policy because I'll go over that question again. I'll go back to that question. Okay, just a second. Okay, so you know, if you have it in the axillary, then you're gonna have weakness in the triceps muscle, so you cannot extend. So the patient is able to extend. So that means it's probably distal to the axillary. Okay, and also the other ones. The other muscle innervated, the supinator is a little bit weaker. He's trying to tell you, and also the rest drop is severe weakness, so it's completely dropped. So that means the extensor carpi radialis longus and brevis are affected. Okay, so that goes in that area. If you have some wrist function, then it's going to be a little bit. He went. Let's go to the next question and then we'll.
A patient present with weak finger extension and mild wrist drop with radial deviation. Elbow extension and flexion is strong. Normal sensory exam. Which is the lesion most likely to be located? It should be posterior interosseous nerve because it's pure motor, and because there is like radial deviation because of the extensor carpi radialis longus and brevis are spared.
Okay, this is kind of like show you here, and here's the spiral groove, and this is what we call Saturday night policy. At the elbow, we meant that it affected the other branches. This is from again Professor Musab. So this will divide the extra muscle. But for you, the most important thing, this is axillary spiral groove or pen, posterior. And whenever he tell you in the exam that there is radial deviation, that means he's implying that the extensor carpi radialis longus is still intact. Okay. I mean, this is just showing you the median. Shall we stop here or do one more question? Okay, let's do this one. Okay, Rasha?
What muscle is innervated by branches of both median and ulnar nerve?
Yeah.
The flexor
Yes.
digitorum superficialis.
And
We have flexor digitorium profundus.
Profundus.
So the one and two is median, and 3 and 4 is ulnar. They like to ask this question. Okay, and you know it's important. The flexor digitorium. I don't know if I have a question. Okay. They like to ask about the anterior interosseous nerve. So if a patient has a lesion in the anterior interosseous nerve, what can he do? The OK sign. Okay. So they love to ask about this. So the anterior interosseous nerve innervate the flexus pollicis longus, you know, which do the first part of the OK sign, and the flexus digitorium profundus to digit 1 or to the index finger, so that Y, and the pronator quadratus, which is very difficult to examine in the EMG and very difficult to examine, you know, even as a pronator. So the OK sign. If you cannot do the A sign, the O sign, then that's, you know, suggest anterior interosseous. And remember, anterior interosseous is a pure motor, so you don't have any sensory. He may have some pain, but when you do sensory exam, he cannot do that. So, and another thing in the median nerve, you know, we know the most common entrapment is the entrapment at the carpal tunnel, which gonna affect what we call it loof, lumbricalis, opponens pollicis, abductor pollicis brevis, and flexor pollicis brevis. Okay, so these are, if these muscles are involved with numbness over the first 3 fingers, so that goes with the carpal tunnel. Now, if you have more involvement, if you have, you know, involvement, if the pronator teres is involved, which is the first branch, that means the lesion is proximal to the pronator teres. Okay, so sometimes, I mean, you can have a Strother ligament, you know, which you can see sometimes in the X-ray, and that compress the nerve, or you can have pronator teres syndrome. Now, usually the pronator teres syndrome, the pronator may be affected or preserved, depends on the innervation. Okay. Let me see if we have any more questions. Okay. Shall we do this or stop here? Let's we'll ask Mus'ab to do the last question.
35-year-old complaining of right hand weakness. He works in the construction industry and uses his palms and hands for manual. He does not report any sensory loss. His median motor and sensory studies were normal. Ulnar motor study with abductor digiti minimi recording and ulnar sensory study were also normal. Needle EMG revealed active denervation in the first dorsal interosseous muscle, but not in the abductor digiti minimi or abductor pollicis brevis muscle. So, yeah. Which of the following is the most likely cause of his weakness? Medial cord brachial plexopathy, anterior interosseous neuropathy, ulnar neuropathy in the forearm, ulnar neuropathy in the palm. It should be ulnar neuropathy in the palm.
Okay, that's correct. I mean, because I mean, you can have different pattern, but the sensation is intact there. You know, the last question is very difficult. It's not very difficult, but it's kind of like a neurophysiology level. Many of the questions are, you know, some of them are simple and they are resident level, neurology resident level. Some of them are in neurophysiology level. I mean, these questions mainly gonna cover the brachial plexus. So if you know how to answer these questions, I think you can answer any brachial plexus question. Do you guys have any question?
دكتور حتى slide number 4 بتاعت السنسوري action potential دي
Number
بس
4.
4 or 5.
Okay. This is 2. This is 3. This is 4. This is 5. This one?
Yeah, snap is the snap here. Yeah.
Oh, yeah. So the snap here, you know, if you have radiculopathy, for example, patient will complain of numbness. And if you examine him, you may have a dermatome, numbness in a distribution of a dermatome. But if you do sensory nerve conduction study, it should be normal. There is rare exception. Sometimes L5, the nerve root can be proximal, so the dorsal root ganglia can be pushed, and then you may have some sensory abnormality. But this is the exception. The rule is it will help you if somebody have sensory symptoms and you do the snap and it's normal. It does not rule out radiculopathy. If you do the needle and you see the innervation, that fit with the picture. Did I answer your question?
Yes.
Any other questions? Okay, guys. So next Tuesday is gonna be Abu Naib. He's gonna talk about the olfactory. Now, is the time 8:15 good, or you guys want it to be a little bit later than that, since there is no rounds, official rounds? I think many people are sleeping by this time. What do you think, Abu Naib? What do you think, guys?
I have no problem as you like.
Okay,
we
so
can asking,
is 9 better?
We can try 9 next
9?
Tuesday.
9. I think everybody is here in the room with 9. 9 is okay. Okay, so we'll do it at 9. Abu Naib, are you going to be awake by 9? Or you need a wake up call? Okay, guys. Thank you for attending.
Okay, thank you, Doctor.
I mean, if anybody is interested, please invite him. I'm thinking in the future to invite even people outside Qatar, from other neurology residency program or internal medicine.
Dr. Hatou, the presentation will be loaded in the drive?
It was recorded, but not from the beginning. We'll get you
because
the slides, unless I use it for
involved.
the Arab Board of Neurology. If I load it, I will not use it for the exam, for the Arab Board in the future. So you guys want me to load it or not?
Not loaded.
No.
Okay. Okay. But okay. Thank you, guys. Any question?
So,
thank you for the medicine people who attended. We have 3 from medicine, so almost. Okay. Have a nice day.
Mohammed, I have a question.
Okay, who has a question?
Right. This is Naeem.
Yeah,
so next topic you said is on olfaction. What do you mean? It's like anatomy.
Olfactory nerve. Anatomy, neuroanatomy.
Oh, okay. Wow.
We're using braces, so now we're gonna move to the cranial nerves.
I see. Okay. And wow,
you hear me, Dr. Naeem?
What? Yeah, I hear you. Can you hear me?
Yeah, I can hear you. So so now we finish the nerve muscle. So the next thing we're gonna go to we're gonna start with the cranial nerve 1, 2, 3, 4 until we finish them. To the cortical function and the brain.
Okay. And you all have the book.
We have the book, and if you want, we have it. If you need, and if you need a copy, it's Google Share Drive. We have everything in Google Share Drive.
Oh, okay.
We'll send you a copy.
Okay, very good.
We will not send you a copy for copyright. We will not send you a copy. I'm blinking.
Yeah. Yeah,
Yeah,
I just don't think that I have the most recent edition of that book.
we have 2016.
Yeah,
But
okay.
if you will give us the hard copy, everybody will thank you here.
Okay.
Okay, take care.
Okay, thank you.
You're welcome.
Have a good day. Bye.
Thank you. Nice.
who are not copyright distributing it. We cannot delete the portion of that.
نعمل recording ولا نعمل ليف مفروض صح؟ meeting for